All right, so this is the June 8th session of Topics of Trauma Nursing. So welcome to everybody. I'm thrilled that you all could be here tonight. We've got an excellent speaker here tonight. Absolutely adore her. Loved working with her for the brief time I got to work with her, but also I get to work with her on a lot of educational things outside the hospital. So I'm thrilled about that. So a little bit about topics in trauma nursing. If you've never participated before, get the slide to go forward. It's a quarterly education offering, and it's really designed to bring cutting-edge topics in trauma care to you emergency and trauma nurses in New Jersey. And it is New Jersey centric because we're all Jersey nurses, but some of the people who are participating on the YouTube channel are, as where YouTube is, from everywhere, which is kind of cool. The goal of topics is pretty simple. Just participate by sitting back, enjoying, but please ask questions. And then recruit more nurses for the next session. What I'll ask you to do toward the end is I'll put, and I sent it out in the email this afternoon that hopefully all of you got, but I'll put it in the chat box before the end of the session. Is I'll give you a link that'll take you to SurveyMonkey for you to fill out an evaluation and get your CE credit. If you are so inclined to want CE for tonight, I'm offering 1 CE credit for this. And then also as part of that survey, give me your demographic information and let me know if you want to be put on the mailing list. And if you've done it in the past and you've already said you want to be put on the email list for future programs, I've already got you. You don't have to do it again. But if you're new and you haven't done it before and you like what you see tonight, trust me, you'll also like our sister program, which is the Trauma Nursing Journal Club as well. As I mentioned, all the sessions are recorded. They're on YouTube, and I'll send out a link to the recording that you can listen to. You can send it out to your colleagues if you find the information here to be helpful, and just talk it up amongst your friends and family. And if you like tonight's session, you'll definitely love the Trauma Nursing Journal Club. It really is a nice way that I found to bring some of the interesting stuff from both the trauma literature, and particularly I try to put an emphasis on trauma and emergency nursing toward trauma literature, and just do a session where we talk about an article that's of particular interest to what we do in our daily avocation, and then kind of, just banter around a little bit. And I'm trying to kind of make reading research and understanding research a little bit more user friendly. It doesn't have to be it doesn't have to be overwhelming like it is for a lot of us. And nurses in general, particularly clinical nurses, have suffered so long for not really being able to or wanting to read some of the nursing literature that we see. If you go, certainly if you belong to ENA, you get the Journal of Emergency Nursing. You know that a lot of that is very research centric now. The goal of the journal, because I sit on the editorial board, is actually going to switch a little bit back to being more clinical. Jesse Kastner, who was the editor-in-chief for a while, left. They're recruiting a new editor-in-chief, and an emphasis within the editorial board is to bring more clinical-focused articles to Jen, which I think will be great. But there still is research articles there, and you have to be able to read those research articles and understand them, and not just do a lot of people do and read the abstracts and move on with what people say. So at any rate, I belabor that and say, look, if you like what you see tonight, then you definitely should sit in on a Trauma Nursing Journal Club. Our next session for that will be either late July or early August. I haven't decided on a date yet, but I'll let everybody know once that happens. And that also carries a CE credit. So let's talk about tonight. So we are thrilled. I am thrilled to have Cathlyn Robinson here. I worked with Cathlyn for like a whopping, how long, Kath? Like maybe 6 months at St. Joe's before you went on to bigger and better things. But it was absolutely wonderful. And Cathlyn is a phenomenal educator, and I'm actually thrilled to have her here tonight talking about damage control resuscitation. This is a reprise of a talk she gave at the ECC conference, or New Jersey ENA's ECC conference in Atlantic City earlier this spring, and it absolutely was a great talk. And I think I went up to you directly after you were done and said, hey, can you come and talk on topics? And she said, yeah, I'll be happy to do that for you. So I'm thrilled to have you here tonight, Kath. So thanks so much.
Thanks.
The requisite information for continuing education. The Institute for Medical and Nursing Education is accrediting this for up to 1 contact hour. Once again, I'll give you the link information at the end, so you can go on, you can fill out the evaluation, and then you can claim your credit, and then I will email you a CE certificate within the next couple of days. If you have any questions or comments during the actual talk, make sure you just mute your microphone, put your questions in the chat box, or if you want to hang on to them in the end, we will have an open forum toward the end that we'll be able to bring everyone up on screen, and we'll be able to have like a real conversation, like we were at a real conference where you can talk to Kat and ask her any questions that you might have in regards to the topic tonight. And that is it. So what I'm going to do is get out of this mode and stop sharing. And I'm going to turn control over to you.
Thanks.
And let's see here. Oh, come on. Let's me. Make host. There you go. Boom. Ball's in your court.
I got it. Okay. Well, you guys, thank you so much for joining Steve and I tonight. It's nice to see some nurses in a different, totally different forum. This is very cool. Just very briefly, I'd like to know where you work. And so if you could just sort of one by one, I'm going to call your name, just come off mute really briefly. Let us know where you work. And if you want to say something that you love about trauma nursing, I always like to hear about that too. So Elizabeth, I'm going to make you go first because you are in the Hollywood Square next to me. You're on mute. Try again.
This is the very first time I've done this. Can you hear me?
Yep.
Okay, perfect. I just got work. I work in the ER, a community medical center. Were you able to hear me okay? Okay.
Good. Okay, Tara, you want to go next?
Hold on. Okay. I'm so challenged when it comes to technology. Okay, you can hear me now, right?
You can hear me now, right? Yes.
Okay. So yes, my name's Tara Sanseverino. I've been a nurse for 11 years and 10 have been in emergency nursing, and 7, 8 in trauma. And I work at Robert Wood ER. I started my career in Capital Health in Trenton, where I learned to love emergency nursing, and that I was sold, and then came up this way so I could be closer to home. And I'm very grateful to be a part of Robert Wood's ER, and it's nice to be a part of the lecture tonight. So thank you.
Great. Kat Gavin, how are you, kitty cat?
I'm good. Hi, Kat. I miss you. So my name is Cathlyn Robinson. I work at St. Joseph Patterson ED. I've been an ER nurse here for 17 years. I was a staff nurse and charge nurse, and then now I'm a nurse manager at the ED. And I don't think I can see myself elsewhere than doing emergency nursing. So that's why I'm still here. And I work with Kat. She was my educator a couple of years when she started, and she really helped me a lot in my profession and helped me a lot where I am right now.
I miss working with you guys. Anne Boltier. I'm saying your name in the French Canadian way.
Hello, hi. Yeah, so I have been a nurse for 3 years, almost 3 years in August. I work in the ICU, so I'm not much trauma, but more of critical care. I get all the trauma after. And it's funny because I just applied for St. Joseph. Yeah. Sorry.
Which ICU do you work in? Where?
Oh, I'm Bronx Care.
Bronx Care.
Okay. Yes, in the Bronx.
Okay. And are you Anne Boltier or
Anaïs
Boltier? Okay. Excellent. Where are you from?
Nationality, the Dominican Republic.
Okay. Because I'll let you guys figure out where my accent's from. Because I'm not from here, and I'll see if you can figure out my accent. That's why I know your last name. Okay, Ginny. Ginny.
Hi, sorry I'm a little late to the party. Just got home from work. I'm Ginny Kurz. I work at the JFK Satellite ED. I've been a nurse for, well, in 2 weeks it'll be 38 years. 35 of them in the emergency department. We went through a lot of changes. We were Muhlenberg Hospital in Plainfield. We had I guess, our little mini knife and gun club in suburbia. We changed to a satellite ED, and we still get the traumas walking in. So, but overall, our acuity is much lower. We have very limited resources. There's 2 nurses to start, 3 nurses at 11 a.m. and then go back down to 2. So I like to keep up on as much trauma as I can, education, because, we see it so infrequently, but, with the high acuity. And then we have a lot of unique challenges being in a satellite ED because, 1 physician, 2, 3 nurses, and 1 tech registrar, secretary, jack of all trades or ancillary staff. So it's always a challenge with trauma. So I try to stay as current as I can. And so that's why I'm here tonight, and I made it home in time, so I'm happy.
Atta girl, atta girl. And Ginny is very involved in the New Jersey ENA, so she's your guru there. Shiloh.
Hi, I am currently at St. Joseph's Patterson's. I am the lead trauma data analyst there. My connection with trauma nursing, I've been about 18 years now with a trauma database. So I collect a lot of the information that the trauma staff is putting in, and then correlate with the ACS, American College of Surgeons, and the states. So that's I'm always wanting to learn more about trauma as well.
Shiloh is our data guru. I will go to her and say, I need to know how many patients that are gunshot wounds to the right pinky have come in the last 12 months. And she'll zoom me pivot charts and animations and stuff.
That's awesome. Well, that's very cool. And I think interdisciplinary work for this is really important. So I'm glad you're here. That's awesome. Okay, well, we'll get started. I'm going to share my screen, and there we go. Okay. So I'll tell you briefly about myself. I have been a nurse for a long time too, not quite as many years as Ginny, but getting there, 30 years. And mostly I started off tele ICU, and then I migrated out to the emergency department. And I've always been drawn to large level 1 academic trauma centers. That's kind of my favorite thing in the whole world. And I was a clinical nurse specialist in trauma for 7 years. So I helped run a level 1 trauma team, and that was fun. I was a clinical education specialist for emergency departments for the past 10 years. And my last hospital was St. Joe's. And I recently, about a year ago, left Joe's to go to the RWJ Barnabas Health System. And I work for the emergency services line, which means we tie all of our emergency departments together with RWJ. And so we are 13 departments now, and I am like the nurse that is trying to pull our departments together. So anything emergency nursing related, I represent the nurses at the system level. So interesting, very different. But I have to tell you, my true love probably is still, more than anything, is trauma and being bedside with patients' families and nurses and doctors. It's still my favorite thing ever. So, see how this goes. It's pretty fun right now. And my hope is to be able to support and impact change for emergency nurses at a very broad level now, which is what I have the opportunity to do, which is cool. So, all right, so let's get started here. And yeah, you guys can see if you can figure out where my accent's from. So in any case, I have a little disclaimer. So like Steve said, I first gave this lecture in March at the New Jersey ENA conference, and then Steve asked me to do it, and then I got kind of lazy. I didn't want to switch the slides around because then I'd have to reformat everything. So everything right now is in the New Jersey ENA format. So Ginny, don't tell, okay? Because it was just so much easier than me trying to go reformat all of the slides. So in any case, that's just, thank you. That's my disclaimer. But it's good advertising for the ENA as well. And a little more advertising. The state conference that we have for the New Jersey ENA every year down at Tropicana in Atlantic City, it's always in March around St. Patrick's Day, is an exceptional conference. It is such high quality. There's always really good speakers, and it's so easy to get to. So I hope you guys can consider coming next year. It's really fun. And this year, what was fun for us as well is that Steve and I we did a workshop together. Ginny was a massive volunteer with us, but also we were able to have some of like the nurses from my system who had never spoken at a conference before, were actually had the opportunity to come in and do a session. So it's a really good way to develop yourself professionally. If you've got a really good topic that you want to talk about, there's an opportunity always to learn how to either one, present a poster, or to present an actual podium lecture. And that's a really good thing to do as a nurse. If you can teach it, then you know it. And it's nice to share what you're passionate about. So that's why Steve and I get roped into doing lectures at these things. We think it's kind of fun, but that's where, disclaimer, this is where this lecture and why we have the slides we do. So no conflict of interest, no disclosures, happy to be here. Just want to share with trauma nursing topic. And just in terms of the objectives tonight, we are going to be talking about something called damage control resuscitation. And I want to talk about the key concepts of it and talk about a case study. So there's a few reasons why you might have wanted to come to this lecture tonight. And part of it is that, you might have been sort of thinking, I'm interested in trauma nursing, and I'm interested in anything that says damage and control. And, if you're a control freak like me, my husband says I'm a complete control freak in the kitchen, which I am. I'm also a bit of a control freak in trauma bay. I want the trauma to be run a certain way, and I do it very professionally and nicely, but I want things done a certain way. So maybe you're a bit of a control freak, so that appealed to you. Or maybe you just took TNCC, the 8th edition recently. Actually, Steve and I are teaching it on Saturday and Sunday. Maybe you took the 8th edition recently and you were totally inspired by the fact that finally ENA is addressing the whole concept of limiting fluids in resuscitation. Probably not, but you know what, that made Steve and I extremely happy when we read that chapter on shock and we saw the changes that they had made. That's the geeks. Steve and I are both self-proclaimed geeks, and we're very happy about that. Or maybe you're just a really massive trauma glutton, and I think you are all probably just really interested in trauma. And that's why you want to be here and to talk about this concept that is actually sort of cerebral. But damage control resuscitation is a pretty interesting topic, and I have to admit it's something that I think is really a consideration that we all must be thinking about as we are caring for our patients in the early phase of resuscitation in the emergency departments. As emergency nurses, this has to be one of the things that we're thinking about and that we're responsible for along with the team. So this concept is a bit of a beast, but we'll get into it together, and we'll try to keep it light so that you can walk away and go, okay, so this is why I'm thinking I want to approach trauma resuscitation this way. So I don't know if anybody here is a Game of Thrones fan, but this is there's a few images on here if you recognize Game of Thrones, and we're going to have a couple more that you'll recognize as well. But trauma nursing is not really a new thing. In fact, Florence Nightingale, who of course we all love and epitomize, Flo was the first trauma nurse ever, and she was also the first infection prevention nurse, and she was the first holistic care nurse, and she was everything. But she was providing trauma care very, very early on. But even before her was this magnificent nurse, and she's from Game of Thrones, and I don't remember her name, but she was a hardcore trauma nurse in battle, saving lives. And trauma nursing is not new. And then you got that one in the cap over there. And yes, indeed, when I graduated, we still got capped. So I've been trauma nursing also for a long time. Not as long as the other two, but for a long time. But the reality is, when I first started working in emergency departments, trauma nursing was a little bit different. When a patient would come in, let's just say, we would have somebody come in, we would get really excited about it. We would get our lead on, we'd jump up and down, you'd get your team ready to go. And at the first trauma center I worked in, level 1, we had one resuscitation room where we put the patient on, like in the middle of this x-ray room, we'd all lead up, and then we'd stick them on this bed, and we'd run films as we would, like simultaneously we would just scan them head to toe, and then we would resuscitate them. And we would just, just go full on hardcore. So let's say, for example, we had a patient like this guy, young 28-year-old male, who came into the ED after being assaulted by a group of men. Let's just say this is a hypothetical situation, which we've all seen in our department, someone who gets beaten up. So, you do your cross-room, patient arrives, you do your cross-room assessment, and what you see is that he has got bleeding from his head and his abdomen, and he's calling out, and he's confused, and he's moving his extremities. but there's no massive active bleeding that you have to control right now, so you can move on and look at your airway, breathing, circulation, disability. So I'm going through the TNCC algorithm with you. So your A is going to be, your AVPU. Well, he's kind of confused and muttering. He's in C-spine precautions because someone remembered to do that and they were, overzealous. Ask Steve how he feels about extrication collars. He doesn't really love them. But they put a collar on him and his airway is clear. He's moaning and he's got some blood in his mouth, but it's not terrible. So his airway's okay. Move on to breathing. His breathing is spontaneous at about 30 breaths per minute. It's shallow and rapid, but he is breathing and he's quite pale. He's very pale. When you go check his central pulse is 130. He's diaphoretic, cool to touch, and he's very pale. And his blood pressure, when you're actually able to palpate to do a manual pressure, is 78/50. So obviously, we've got probably some issues with hypovolemic shock. And then you realize that you lift up his shirt and he is actually bleeding from his abdomen. But he's a GCS right now of 11. He's Pearl. And when you actually finally get him exposed and get him to be a little bit more trauma naked, you realize, oh, yeah, his belly looks pretty distended. So you get him covered up and team gets excited. We throw in a bunch of 14s and 16s because, the bigger the better, and trauma is bigger than IV as you can ever get in, whether it's necessary or not. And throw up a whole bunch of fluids, some saline on one side, some ringers. We start pounding him with fluids because his pressure's low and, we got to get his pressure way, way up. And fluids are the best way to do that. Fluids the only thing. Remember, this is 30 years ago in the ED, okay? 25 to 30 years ago. And, he's getting a little more cold and we do a DPL. I'm not sure if any of you have had the opportunity to do a DPL. Very old school way of figuring out if someone's got blood in their abdomen. And you start throwing up some O negative and get some blood going. And finally, we get this poor guy up to the OR. We spend like an hour resuscitating like crazy. We finally get up to the OR. And in there, the surgeons just, do their very best. They spend hours trying to repair this big liver laceration that he's got and trying to close things up, control bleeding. They're fluid resuscitating him some more, giving him some more blood. Meanwhile, this poor guy is getting colder and colder, more acidotic. He's in massive hypovolemic shock, and he starts going to multi-organ dysfunction, ARDS, and unfortunately, he eventually dies. So it was a very sad moment for Jon Snow, if any of you guys are familiar with Game of Thrones. So why is it that after so much effort, so many resources went into this young man, with all of this really, really aggressive resuscitation, why didn't he live? What was the problem with this whole scenario? Like, we followed the algorithm, we gave him fluids, we got a little bit of blood into him, we did our very best with him. So what was the problem? Well, what we started to realize when we started looking back over a lot of these chart reviews, and this is why actually it's really nice to have somebody here who does the data collection for our emergency departments, because what we learned so much by doing chart reviews and by having an understanding of how our patients do and what their outcomes are like, and by what we've done in their journey. And what we started realizing is, sometimes when we keep them in the trauma bay for too long, they don't necessarily do better. And geez, when they're in the operating room for hours and hours and we're trying to repair every little thing, they're not doing so well. So what ended up happening is the trauma surgeons really looked carefully at this, and they started to develop something called damage control resuscitation and damage control surgery. And those two things have been key to helping our patients to live despite really, really terrible traumatic injuries and where they're bleeding profusely. So all of you who work in emergency departments understand that hemorrhage is one of the leading causes of death after injury. If someone's bleeding, we're going to do everything we can in that moment when they arrive to try to control their bleeding. Because if we don't control their bleeding, they're going to bleed all over the floor and they're going to not make it out of our department. They're going to die. And that's got to be our priority. What's a little scary about hemorrhage, though, it's the leading cause of preventable trauma deaths. And so that means that we're still not doing bleeding control perfectly, and we're still learning about how to do it. The other thing too is that the lifeblood of somebody pours out of them very, very quickly. And so it's really important that we are able to really react quickly and care for our patients comprehensively with only minutes to spare. So this brings us to a little bit of a description of what actually happens when somebody gets hurt. Well, when somebody gets hurt, we call that time zero, okay? And you can think about time zero anytime, whether it's a brain injury or whether it's, any sort of assault. That's the moment that the patient got hurt in the field. There's nothing we can really do about that moment in time. That's the first hit that they take. That's the injury. But what happens physiologically in that first hit is the body really, really reacts by activating a number of compensatory mechanisms. That's part of the easiest way to describe it. The body just kind of goes, oh my God, just been assaulted. I got to do everything I can right now. And it goes into overdrive to try to help itself get better. And it ends up, what it does is in response to this sort of insult, these compensatory mechanisms end up sort of what they start off as good things. They start off as ways to try to save the patient's life, and our bodies will do this naturally. But unfortunately, these compensatory mechanisms are only good for so long. And what we wind up with is something called the trauma triad of death. And even saying that is fun. But what ends up happening is this lethal triad is in response to this initial pathophysiologic response to injury. So we get that first hit, and unfortunately, boom, we get this response, which will end up leading our patients into the trauma triad of death. And unfortunately, unless we stop this vicious cycle, and it is a vicious cycle, your patient's not going to do very well. So we have to look very carefully at these three components and see where we can stop or correct or prevent our patients from getting any further into this triad. If your patient goes spiraling into this triad, it's like circling the drain. And you've all seen patients circle the drain in the emergency departments. Once they start to circle, it's really hard to get them back out. And it's the same thing with this trauma triad of death as well. So what we're going to do is we're going to talk a little bit about these three components. So you understand what I mean by this triad. So when you're looking at the three pieces, it's three pieces. It's coagulopathy or blood clotting, acidosis, and then also hypothermia. And as you can see, all of these things keep affecting the other when you look at sort of this rotation, and they kind of go back and forth, but each thing will impact the other, and it will exacerbate the patient's blood loss. And unfortunately, if they don't stop bleeding, they're not going to live very long, right? So let's break this down. So the first thing is coagulopathy, and that's essentially clotting. So when patients have that initial insult, what happens is that they end up having this trauma-induced coagulopathy. And 25% of the patients, by the time they get through the doors of the ED, they are already engaged in TIC. They have TIC on arrival. Not everybody will already have this trauma-induced coagulopathy, but remember, 1 out of every 4 will already start to be having some bleeding problems if they are already bleeding. And what this is it's like a reaction to this, it's an inflammatory and metabolic reaction to damage to the tissue and to hypoxia and direct tissue injury. And unfortunately, what this will do is it will end up compromising the patient's body and its ability to clot. And so the patient winds up, not clotting as well as it should. And, you think about it at the beginning, when the body is bleeding, the first thing the body's going to do is going to go, oh my God, I'm bleeding. And it's going to try to form clots wherever the body is bleeding. Well, unfortunately, what ends up happening is as the clots are formed, it's using up all of those clotting factors. And then guess what we do? Remember I talked about all those fluids that we flood our patients with? You flood them with a whole bunch of normal saline and Ringer's lactate. Too much? Oh, now we've hemodiluted them, and we're no longer, the body doesn't have enough clotting factors. It's clotted as much as it can, and now it's diluted, and there's no more. We're giving the patient water. We're not giving them clotting factors. So you can see why it's kind of they're already compromised when they get here. They get worse as this inflammatory response continues on, this metabolic response. Then we flood them with fluids. They've already exhausted their clotting factors, and so they're just going to keep bleeding. Okay, they're going to keep bleeding and bleeding and bleeding. Some of it is we can't even really prevent it. We have to watch for it, but just know that no matter what, one of them will arrive already bleeding worse. Second piece is acidosis. So when we think about shock, one of the things we need to always remember about shock is a perfusion problem. Okay, and I'm really simplifying it, obviously, but think about perfusion. So let's just give it a cardiac moment. Let's say a person's having a big MI. The reason their blood pressure is so poor is because the heart muscle is not pumping, and so their heart is not able to spit the blood out to the periphery, and so obviously the blood pressure is low, right? Because the heart doesn't have the strength to push out, and what ends up happening is the tissues are not perfused. We have a perfusion problem. In trauma, the patient gets hurt, they start to bleed. Rather than the blood staying in their intravascular system, the blood is either going somewhere inside their own body or it's spilling out on the floor. So they're losing their intravascular circulatory volume. And so there's not enough blood to actually perfuse the tissues, and our patients wind up in a shock state. If we don't perfuse the tissues with oxygen and nutrients, we can't feed the cells. We also can't take away waste. And what ends up happening is your patient winds up in an acidotic state. So you have to sort of remember, this is what shock is. It's the lack of perfusion that leads to acidosis, okay? In any case, when a patient has a pH that's like less than 7.4, unfortunately, this will end up prolonging clotting times. It also will do things like the cardiac contractility is not very good anymore. Cardiac output's not good, so they're not able to push whatever blood is left around. The tissues are not being perfused properly, like we talked about. The shock and the acidosis gets worse. There's profound vasodilation as a result. The clotting times, it's prolonging clotting. The clots are not as strong, and the bleeding continues. And if they keep bleeding, the perfusion is going to get worse and worse and worse, because there's nothing in the intravascular circuit essentially to perfuse the tissues. So you sort of have to think about it that way. It's like, oh God, you can see how it's just really, really cycling around on itself. And unfortunately, what will end up happening is if the patient doesn't have any intravascular volume to perfuse its tissues, again, they're going to wind up either in DIC, they're going to wind up in multi-organ dysfunction, and eventually they're going to end up dying because they're not perfusing the tissues and they're in such profound shock. And then when your patient gets into, a severe shock state, remember, it's very hard to get them back out of it. And if they go over that if they cross that line into severe shock, and you're maybe not going to be able to save their lives. Now, we'll talk a little bit later about bicarb, but I'm going to tell you bicarb is not a solution to this. What solves the acidosis problem is correcting the perfusion. So you give them appropriate volume to perfuse the tissues of a suitable product like blood. Perhaps you perfuse the tissues more appropriately with blood, oxygen, nutrients, and then the tissues will start to correct themselves. The acidosis will correct. And, that obviously takes time. The last piece of this trauma might have death, hypothermia. And a nice warm day like today, you don't think about it. However, your patient still can become hypothermic in the trauma bay, even on a nice, lovely 85-degree day like we had today. Because what's the first thing you do when your patient gets into the department? Well, you strip them trauma naked, okay? You expose them to the world, even if you turn up the heat in your trauma bay, which most of us do not do. You strip them down, then you give them a bunch of cold fluids, give them cold blood, and unfortunately, they become hypothermic. And what does hypothermia do? Well, have you guys ever had to try to resuscitate a hypothermic patient, like somebody who's been caught in really, really cold water? I don't know if you've ever experienced, but their blood pressure is poor. They've got poor cardiac contractility. You've got to get them warmed up for anything to really work. Vasopressors won't work. It's a really challenging experience because you've got to get their bodies warm for anything to any of the interventions that you want to try to be effective. So in any case, what ends up happening with hypothermia is it's obviously the cold fluids, cold blood, the exposure ends up, disturbing the normal metabolic pathways. Platelets don't work very well anymore. They don't clot very well. And the patient can become hyper or hypocoagulable. And often the patient just keeps bleeding. And if this happens, we know that severe hypothermia in the trauma bay has an incidence of increased mortality. So we have to keep our patients warm. And this is why, it's a very specific thing in TNCC. What are 2 methods that you're going to use to warm your patient? and this is why it has to be. This is why you warm your fluids, why you warm your blood. You have to keep the patient as normothermic as possible. So unfortunately, this cycle of violence essentially is happening with your patient unless you in a very, very concrete, measured way, do everything you can to reduce the impact of each of these 3 factors. Your patient's going to keep spiraling through this terrible, terrible situation, and it just continues to sort of feed on itself. And like we said, it's a cycle of violence, cycle of destruction. They're not going to get better. So it doesn't just end there, and I wish it did, because then there's the second hit, and we didn't even talk about that piece yet. So the first hit really happens in the trauma bay, and then it kind of extends itself because we do all this resuscitation in the trauma bay, and we make things worse if we're not careful about it. But then the second hit is actually when we take them up to the operating room, and the patients who are really bleeding badly, they need surgical repair, and that's one thing that's cool is that we actually can fix things if we can keep them stable enough to get them to the OR. But in the second hit, what's tough is that in the old days we would take them up to into the operating room, and the physicians would work for hours and hours and hours and try to fix every single thing, and they would fluid resuscitate, and they'd give blood, and the patient would be cold and acidotic, and they'd be bleeding, and then the surgeons would be mucking around in the and all the intestines and whatever else inside they're mucking around with, and then they would try to close the abdomen, but the abdomen was so swollen from all the fluids and manipulation that they couldn't get it closed properly, and then the patient would wind up with a swollen belly that's barely closed, and then they would wind up with abdominal compartment syndrome, and they'd go back to the ICU and they'd be cold and acidotic and bleeding and just oozing everywhere. And when you see somebody who's in DIC and they get oozy, everything oozes blood, and that's what was happening, and it was because of this prolonged time in the trauma bay, all the interventions that we were doing without thinking about it, and then also the time in the OR. So like I said, the surgeons figured out real fast that if they could try to reduce the time in the OR, that they might actually be able to have a better outcome. And this concept is interesting because it actually comes from the Navy. So there's something called this whole idea of damage control surgery comes from a term that they use in the Navy where they try to control damage to a ship. So say, for example, a ship has an injury, we call it an injury, or let's say, I don't know, maybe it runs with an iceberg, I don't know. But in any case, the only option really is try to fix that problem temporarily or long enough to be able to get back to port or wherever they are. So what they would do is that, people would be downstairs wherever they are in the holds of the ship. Obviously, I'm not a naval officer or anything, but they would go down and they would try to repair the problem in the ship real time while the ship is still floating, just in an effort to patch things up enough to be able to get out of there. And OR is kind of similar. What they're trying to do in the OR is they go in and they have an abbreviated OR where they'll take the patient in, let's say it's an open laparotomy, they do the full laparotomy, and let's just say like our guy, John Snow, has a liver laceration. Well, they're not going to take out the liver, obviously, because livers are cool. They're very vascular and they can regenerate. But what they have to do is they've got to get that big liver to stop bleeding. So what they will do is they will control as much bleeding as they can. They will pack the liver, pack the abdomen as best they can. And then rather than trying to pull that belly closed, because the patient's probably still going to require fluids, going to require blood products, they will be swollen, and they'll be swollen from the manipulation probably as well. But what they will try to do is they'll pack it as tightly as they can to control the bleeding, nice tamponade effect. And then rather than trying to pull the skin closed, what they will do is they'll put a big sort of piece of material on top, like often it's things like Dacron. I mean, in the olden days, I think Steve said this when we were talking about last time, it used to be they'd take IV bags and where they're sterile, they would sort of put them on and suture them in place so that when the patient went back to the ICU, what they would do is they would rewarm them and, fluid resuscitate, or more like blood resuscitation, get them hemodynamically normal again, get them warmed up, correct the acidosis, get them perfusing well, and then they would also try to get some of the fluid off of them so that belly would start to shrink. And then when the belly was a little more settled and the bleeding was stopped and the patient was warm and stable, what they would do is they go back to the operating room and then try to take the packing out. And by that point, the bleeding settled down, things are less swollen, they can see what's going on and do any more repairs that they have to. And then hopefully they're able to close. Now, I'm really simplifying this, obviously. I am not a trauma surgeon. I don't have the privilege of going in the OR, but that's essentially what they would do. But sometimes, it's good to see what's going on. I hope this is going to work. I'm going to play you guys a little video. And this comes from a Korean team that was doing a crash laparotomy. And this is sort of what they do for damage control resuscitation or damage control surgery. But you can see the manipulation. No wonder the patient gets swollen, okay?
It amazes me how quick it went from that field being full of blood to now it's dry, relatively dry.
Yeah. So in any case, if you go online, if you just even Google Korean damage control surgery, there's a team, and this comes from soup to nuts. It's really interesting. But we don't have to watch the whole thing, but it is certainly, you can see it, pretty interesting. And what eventually they do is they go in and kind of finish off the surgery, but they'll pack it. So what always amazes me when you watch a video like this, for example, is that I don't know how the trauma surgeons know what's what half the time because there's so much going on, but they just know their anatomy so well. And they know that time is of the essence. There's only so much they're going to be able to do. They got to get the major bleeding controlled so they can move on to the next, to the next part of the resuscitation and try to get this patient going. Okay. All right. So what we've learned so far is that the patient is going to have a first hit. That first hit, there's nothing we can do about it. They're going to arrive with TIC, trauma-induced coagulopathies, 1/4 of the time. And they, that injury has happened, but we've got to do our very best because that trauma triad of death is out there waiting for them. And then we know that if we don't resuscitate really carefully and quickly, and with, keeping that trauma triad in mind, that second hit is going to take a toll on our patient again. But that damage control resuscitation done well and damage control surgery done well can really help impact the outcome of our patient. Okay, so we have learned that so far. Okay, that makes sense. So what can we as trauma nurses do better? Well, what we need to be doing is bringing damage control resuscitation to the trauma bay. In some places, what they will call this actually as well is they'll call it hemostatic resuscitation, depending on what you're reading. There's lots of good YouTube videos out there as well on this as well. It just depends what you're interested in watching it. But what we know is that really that this whole kind of concept really depends on sort of different factors, and that if we are able to really, really maximize this process, your patient is likely to have better outcomes. So this is why we really need to bring it to the trauma bay. And the first thing we sort of want to consider is that this really has to be proactive. You can't be sitting back and waiting for your patient to be doing something. You have to anticipate what you think might happen. The guy has been stabbed to the right upper quadrant. Perhaps you've got to anticipate, well, we're probably gonna have a lot of bleeding. We need to be prepared for this. We need to be thinking about this. I need to be planning for only so many minutes in the trauma bay. I've got to maximize what I can do in the short period of time. Proactive, keeping my patient warm, proactive, making sure that they're perfusing, proactive and making sure that, my patient doesn't ever have bad hypotension, for example. We have to identify the high-risk patients. In your mind, you have to be saying, I'm listening to the mechanism of injury. I'm hearing I'm hearing the pre-hospital report, and I understand that this is a patient that I need to be very mindful of how I approach their care. And damage control resuscitation can be really thought of for some major injury sort of components. Major abdominal thoracic injuries, significant pelvic trauma, significant amputation, multiple long bone fractures, and head injuries. And we need to be considering all of these things. Now, one of the things to be mindful of, though, is we're going to talk about head injuries a little bit more because you need to be careful when it comes to head injuries. And then we're going to talk about why. And one of the things to be mindful of, too, is that rules don't always work. What we need to be thinking about is clinical practice guidelines to guide you in your practice at the bedside. Rules are kind of like hard and fast. They don't always work. But if you know what you're reaching towards, what you should be aiming for, what is your goal? This goal-directed therapy. These guidelines will help us to find our way. And assessment, reassessment. I mean, we say this constantly in TNCC, but these are the things you need to be considering constantly. I need to be proactive. I need to identify when my patient's getting into trouble, or if they're a high-risk patient, I need to assess and reassess. Because at the end of the day, it's always you at the bedside with the patient. So there's six main concepts that we talk about in DCR. And the rewarming, it's called rewarming, early hemorrhage control, limited fluids in resuscitation, permissive hypotension, target coagulopathy, and then the last one is correction of acidosis. So we're going to talk about each of these and sort of in turn and sort of discuss them a bit further. So the first thing is rewarming. And, rewarming, it comes down to prevention. There's no reason for your patient to be super, super cold. If you are really, really careful in the trauma bay of always ensuring your fluids are warm and making sure that you have the opportunity to give blood warm if you're going to give blood, but also making sure that when you have your patient on the stretcher and somebody pulls off, all their clothes, that one, you are immediately getting warm blankets on them. But also, I'm not sure how many times you guys have seen this. Well, somebody comes in and they whip off their blankets constantly. Try to make sure the blankets stay on. Katie, who works at University Hospital, she's a trauma program manager, has a very interesting way to keep her patients warm. She takes a bear hugger, and you know how it kind of puffs up? She'll put the bear hugger on the bed, and then she puts the patient on top of the bear hugger. So they're kind of lying in this like nice, cozy, air-filled pocket of warm air. I think that's very clever because it's keeping her patient warm immediately. So that's something to consider if you want to try it. Early rewarming is good. We want to make sure we're rewarming at a central and peripheral sort of manner if we can. And there's no sort of specific guidelines about rewarming techniques. Really, the key is prevention. So do your very, very best just to don't let them get hypothermic, but do get a rectal temperature. You need to know what your core temperature is and where you're starting. Second thing is early hemorrhage control. So earlier interventions that are absolutely key are things like tourniquets, and like pre-hospital is using tourniquets much more. I feel like this is absolutely everybody uses tourniquets now. Years ago, we were scared to use tourniquets. It was like, oh my God, don't put a tourniquet on or the patients, they'll lose their leg. Well, now we know that's not true. And actually, Steve is one of the best stop the bleed instructors I've ever met, and does fantastic community outreach using teaching people how to use tourniquets in the field. And he, Steve to talk to you about tourniquets sometime, because there's so much myth around them that they really can be a very, very important tool to controlling bleeding in an extremity. Whereas instead of having the patient bleed out, get that tourniquet on. So one of the responsibilities for you, if you're going to be in the trauma bay, is you need to know how to put a tourniquet on or a double tourniquet very, very quickly and comprehensively. That has to be one of your responsibilities. Other early interventions are things like pelvic binders. There's a few different brands on the market. I tend to like the T-Pod. Steve has another one he likes. I can't remember the name of it now. Or in most places, if you don't have T-Pods, these fancy pelvic binders, you use a sheet and you pull the pelvis together. And the concept is if you've got a shattered pelvis, the pelvis is the bones are bleeding like crazy, and the bones are also very, very, they can be very sharp inside. So if the patient moves too much, those bones can actually start slicing and dicing all the soft tissue inside as well. But if you pull the pelvis together, pull the bones together using a pelvic binder, you can create a tamponade, kind of couple of it, get it to stop bleeding, and it's amazing. You'll see your patient's pressure go up and they'll settle. So it's a very good tool, but also compression. Like, let's just a situation where you can't put a tourniquet on it and pelvic binder is not applicable. Solid compression using quick clot or some other, quite impregnated gauze, whatever your hospital carries, is a really good way of controlling bleeding as well. Other things that we can do to control hemorrhage, there's a procedure called ROBOA, and I can never think of the full name. Steve, if you want to jump in, I can never think of the full. I love acronyms.
Yeah, it's called it's resuscitative endovascular balloon occlusion of the aorta.
There we go. Okay, so if you want to Google that after this lecture, there's also videos on this. Essentially, what the physicians will do, let's say you have a person that comes into the trauma bay and they are bleeding profusely, abdomen somewhere, like down in the groin, wherever. What they can do is they'll go in, they'll put an arterial line in, usually in the right groin. And what they are able to do is they feed a catheter, very long catheter, a bit like what they would use in the cath lab, up through that introducer sheath. And they will feed it up into the aorta. And so imagine this, this big line, this wire is going into the aorta. And at the end of that wire is a balloon. And so what they will do is they will inflate that balloon in the aorta with normal saline. It's got a little way to inject normal saline into this little balloon. And that balloon inflates and it basically prevents, it blocks or occludes the aorta. And so what happens is that all the blood that's coming from the heart down to the aorta, it gets stopped by this balloon. So if the patient has an injury below, blood is not being fed, can't get by the balloon, so blood cannot leave then that wound, for example. Obviously, this is not something we would leave inflated in the aorta for a long, long time, but what it's basically doing is shunting blood back to the vital organs, the heart, the brain, and the lungs, to keep your patient going until you get up to the operating room. Now, what's cool too, as I understand, like, again, I haven't seen this in the OR, but when they get up to the OR, when they open up let's say they've got the ROBOA in and they do an open laparotomy, the abdomen, once they get the clot out, is dry because there's no blood coming down. So you can imagine, like we just watched the video where there's a lot of profuse bleeding. You can imagine that there'd be a much easier abdominal bed to work in because they're not dealing with a whole lot of bleeding. Now, when they take the ROBOA down, yes, the patient would start to bleed again, but hopefully they've controlled repaired what they can before they take that balloon down. That's not a procedure that that's being done very many places. St. Joe's does do it. I always thought it was kind of funny watching the trauma team try to do it because they were so darn excited about using the ROBOA that they would get in their own way, with it, and they weren't particularly efficient. But I think it has a lot of potential, and I don't know, Steve, you were saying not many centers actually use ROBOA. right?
Yeah, very few centers are using it. And, if you're familiar with the resuscitative thoracotomy, which is the traditional method of handling these hemorrhaging patients, is you crack the chest and you cross clamp the aorta, or if it's a thoracic injury, you crack the chest and find the bleed in the chest. And really the Reboa is a cross clamping of the aorta using a balloon, and it's less invasive. But the studies out there are not overly positive toward Reboa versus outcomes, Reboa versus resuscitative thoracotomy. And I think you're starting to find niches, like it's better to be used in hemorrhagic pelvic control versus injuries in, intra-abdominal. But as more and more studies are coming out, we're finding a clear niche for Reboa that I think will eventually kind of come onto its own for certain types of hemorrhagic trauma.
A little more targeted then. Yeah, exactly. Yeah. Other things that as trauma nurse, so Reboa, again, it may not be in all your centers, but it's something that is like Steve said, it's done in a handful of places. Something that you should all be familiar with is TXA, whether it's used topically in a wound or else, given IV. Generally, pre-hospital teams will often give the initial gram over 10 minutes in the ambulance. If not, you mix a gram and 100 cc's of normal saline and you throw it up over 10 minutes, and then you give, there's usually a secondary dose of another gram over the next 8 hours. And there's lots of trials that have been done with TXA as well, and it really does improve outcomes. It's called they're called the CRASH studies. So if you're looking for that, and then really thinking about the fact that we need to, the patient doesn't need the trauma bay in us. What the patient needs is either surgical intervention or they need interventional radiology. So really the priority has to be get them to the place where we can actually stop the bleeding. We can't stop bleeding in the ED. We can only kind of get them stabilized to the so we can get them to the place where they can actually do that. So that's the second thing. The third thing is we need to think about how we limit fluids in resuscitation. So we've already talked about the fact that all that normal saline and emergers that you're giving to them is making them cold. It is not making them clot any better, and it's making them acidotic. So what we should be talking about is something called a balanced resuscitation. We're doing a 1-to-1-to-1 ratio. So you want to have, packed cells, FFP, and platelets, and we should be giving 1-1-1. 1-1-1. Now, not everybody does that either. I don't know what you're doing in New Brunswick, but we would certainly give packed cells and FFP, but the platelets was not the first round. So that's really what is recommended. Now, some sites are doing something new where they're actually going straight to whole blood rather than giving out components. And they're just going straight, well, let's just give them the whole unit with all the components mixed in together. Now, not every site is doing this. This is something that's at Joe's. Steve, you need to correct me. I want to say we started it probably about 2 years ago. And it's only for some patients. It can't be given to everybody. There's a few things where we're not going to get into it. There's sometimes you cannot use it, but it is an interesting approach. It's expensive. There's some concerns. Blood banks don't usually really like it because there's always concern about waste. But when it's used, it's pretty interesting. So probably keep your eye open for that. There'll be more to come on that probably for sure. And then just the idea that when you're going to give fluids, it's no longer the 2 liters right off the bat and then go to blood. You give your fluids carefully. And what TNCC will teach you is give a 500 cc Ringer's lactate bolus. Give them 500. See how they do. It's not that you can't give them fluid, you just don't want to overwhelm them. And if they don't do well before you get blood, give them another 500. But then you gotta think blood right away, because they need the clotting factors and they need the oxygen carrying capacity. So consider that. I'm going to give them 500. Let's get them going, but I'm calling for blood, or I'm reaching into the fridge, or I'm getting the bucket, or I'm calling blood bank. Okay. Fourth one is something called permissive hypotension. This is a little not necessarily controversial, but it's something that a lot of people struggle with this idea. It's the concept, the premise is that if you keep the blood pressure low enough, you will be able to help just reduce the disruption of the clot. So think, for example, you have a patient that gets a stab wound to the abdomen. Immediately, the body does its very, very best to clot around where that injury has occurred. It's creating that clot right there. And the patient's blood pressure is probably going down because they're losing blood, but the body's trying very hard to stop the bleeding itself. And then suddenly you come in and you throw up 2 liters of cold Ringer's lactate and you pummel it in with a rapid infuser as fast as you can, because that's what we like to do. Well, what do you think happens to that poor little clot? The little clot's hanging on by a thread, and suddenly this whoosh of fluids comes through, the pressure suddenly goes up, and this clot goes flying off, and all that work the body did is suddenly gone. And then the body's having a hard time clotting anymore because it's already used up its clotting factors and you're giving somebody saline. So the idea in permissive hypotension is that you give initial fluids, 500, but we're going to accept a lower blood pressure. So maybe a systolic between 70 and 90, and maybe a mean arterial pressure of 50. The idea is don't pop the clot. Don't burst it off of where it's trying so hard to work. Now, this can't be used for every patient. We cannot use it for patients with traumatic brain injury, because remember, you need a certain pressure, a certain tension to continue to maintain cerebral perfusion pressure for your patient. So if your patient's blood pressure goes down in a brain injury, with a brain injury, let's say they've got a bad TBI, their blood pressure goes below 90, you're not perfusing the brain, and unfortunately that's going to wind up with further brain damage. But if the patient doesn't have a traumatic brain injury and their MAP is about 50 and you're keeping them stable, that's perhaps something we can do to try to maintain that clot in place, giving them what they need to perfuse without overwhelming the system. And we don't need a blood pressure of 120/80 in these patients. But again, this has to be a team decision. You have to work with your trauma surgeon and say, okay, what do you want the mean arterial pressure to be? And I really, really strongly encourage you to start using MAP in all of your resuscitation, whether it's a cardiac arrest or whether it is, titrating levo, or whether it's in the trauma bay. Really use your MAP, because your MAP is an indicator of perfusion. And that is what we should be always looking for, is our patient perfusing, okay? Normal MAP, if I can get a MAP of 65 on somebody with sepsis, I'm good. A MAP of 65 in trauma, that'd be fine. You might want to MAP a little lower so you don't rupture that clot. But again, that's a team discussion. It has to be very clear with everybody. And again, not in TBI. Target the coagulopathy. So again, be proactive. Figure out quickly who's going to need a massive transfusion. Be thinking about this balanced transfusion, the 1-to-1-to-1, not just packed cells. You need to give them the other clotting factors. Consider about giving calcium. Every time you give 6 units, you need to be considering that they need calcium chloride or calcium gluconate to replace, because they're going to wind up hypocalcemic. And better to be a little hypercalcemic than hypo. Okay, so just do not try to remember that. If your trauma surgeon doesn't remember to give some calcium, say, hey, did you want us to give some calcium gluconate? If you've given a bunch of units of blood. The other thing is we can use something called TEG, and TEG is a device that is in many hospitals where we take a blood sample, and the blood sample actually helps us to understand exactly what the clotting factor is in deficit. And when you find, it's a computer program where they're looking at sort of the clotting factors on the computer screen, essentially. And I'm really simplifying it, but it helps the surgeon to understand, okay, my patient has these clotting factors, but not these, so maybe we need to give this instead of that. So it helped to understand if it's going to be platelets or FFP or packed cells. Okay, so it's a more of a cerebral way of really looking at what a patient needs instead of just sort of guessing. For example, not every hospital would have TEG. And the last thing is correcting the acidosis. So bicarb doesn't really correct acidosis. We give bicarb all the time, every arrest, let's give bicarb. Well, sure, they're really, really acidotic. But if you got the heart pumping better and perfusing the body itself, probably guess what? The acidosis would correct over time. We can give bicarb. However, the most appropriate thing is to try to improve perfusion. And there's so many things we can do to correct perfusion. So just keep that in mind. So let's just say a couple case studies, and we'll do this quick because we're getting to time. So a 72-year-old male arrives to your ED after falling from his own height. Crossroom assessment, lack to his right forehead, bleeding is controlled. His APPU, he's responsive to pain. He's maintaining his airway and he is breathing. C for circulation, he's pale, warm, dry, strong central pulse, and his blood pressure is 74/48. So he's hypotensive. Is this a patient who would be a candidate for damage control resuscitation? What do you guys think? And you can come off speaker if anybody's got opinions on this. Okay, well, I'm going to tell you no, he's not. Okay, and the reason is a couple of reasons. One, hypovolemic shock, what would their skin be like? Well, they'd be pale, but they would be cold and they'd be diaphoretic. That's hypovolemic shock. This is not necessarily hypovolemic shock. This is probably neurodynamic shock. Also, he has probably got a head injury, so he's not going to be a candidate for DCR. Okay, but let's talk about this guy. 32-year-old male, gunshot wound to the abdomen. The cross-room assessment, active bleeding to the abdomen for his gunshot wound. His AVPU, he's verbal. He's maintaining his airway and he's breathing on his own. C for circulation, pale, cool, diaphoretic, weak, rapid central pulse. Blood pressure, 74/48. It's also pretty low. Is he a candidate for damage control resuscitation in the trauma bay? You bet he is. He's perfect, in fact. So what do we want to do? Well, the first thing is, let's figure out, what do we do for this guy? Well, we need to think about, what would we do for DCR? What are those key concepts, those 6 things that we want to think about? Because we need to anticipate what this guy's needs are going to be. So we're going to reprioritize. What's this patient at risk for? Well, he's at risk for bleeding, obviously, and he's got active bleeding. So we need to stop the bleeding wherever it is, and it's in his abdomen. We're going to hold pressure, and we're going to consider probably using a hemostatic agent. So perhaps you're going to use, quick clot. We're going to reconsider the CABC. It's now circulation, and we're going to then go back to our ABC. And we got to control the bleeding. We just talked about that. What would his IV access be? Well, you want 2 big gun IVs, and as large as you require, but 2 18s in the ACs will work just fine. Fluids, yeah, give him 500 to challenge him. But then consider whether or not this guy's going to need blood, and anticipate. Call blood bank early. Make sure you have blood ready. He's going to need ONEG for sure. Reassess. I gave him 500. How did he do? How's his blood pressure? How's his heart rate? Has his skin pinked up? Is he less diaphoretic? Is he less cold? I'm giving warm fluids. And so airway for airway. Well, if he's talking to you and he's maintaining his airway, good. But this guy's clearly unstable. This is probably a patient you're going to consider needing to carefully intubate, because we don't want to lose his airway. If he gets much more hemodynamically unstable, likely would need intubation. B for breathing. Well, got to keep an eye on his breathing in the meantime, but probably intubation and supporting him with good respirations through a ventilator. Again, that's also another opportunity to help correct acidosis. C for circulation. We just talked about what we would do, right? All of these interventions, but anticipating, looking ahead, what can I do to make sure that I am preventing hypothermia, that I'm preventing coagulopathy, that I'm preventing acidosis. So I'm kind of whipping through this now, but because we're not kind of together to talk about this, maybe I'll just kind of go off screen actually, and I'm gonna stop sharing, and then maybe we can sort of talk about it, because it's easier to sort of look at each other and talk about it. So C for circulation. Tara, you're in the trauma bay. Where's your favorite place to put an IV on a patient who's had a injury to the abdomen? I'm putting you on the spot because
I know I'm trying to get this stupid video. Wait, okay. All right. I'm sorry. Repeat it again.
So
injury to the abdomen, wherever I can get an IV.
Perfect. Okay.
Yeah.
So you know what? If that's the case, you get a line in wherever you can. But yeah, ACs, if you can get 2 18s or 18s in your ACs, that is actually as good as anything.
Yeah.
And worst case scenario, if you can't get a line in because then the guy's crumping and it's terrible, you drill him, put an IO in. No, it's not my first choice, but again, you're gonna have to do what you can. Now, Tara, this guy is a little hypertensive. How much fluid do you want to give him, do you think?
Well, they don't usually start with the fluid. They go right for start putting up 2 units of PRBCs, and we have FFP in there too now.
I know.
Yeah. So, usually if they like to just go right for emergency release to MTP.
Perfect. Okay. Because you work in a crazy place that has a fridge full of blood in its trauma bay. But let's just say it's Jenny. Jenny, what are you going to do for fluid resuscitation? What are you going to do? You don't have blood sitting in the fridge in your pocket. What would you do first?
Okay, well, we have nothing. I mean, we would do the large bore IVs, and we would just start giving them fluid. I mean, that's pretty much all. I mean, if there's, bleeding, we can control it with pressure. We finally, believe it or not, got the tourniquets for, extremities. But yeah, we have, very, very limited resources.
Yeah.
So.
And this is really more the norm for a lot of our smaller community hospitals, that you don't have the blood fridge. Like Tara's a really exceptional situation. And because level 1 trauma center, they should have it. And it's great. You're priming with blood. That's awesome. But for Jenny's going to get 500 bullets. See how the patient responds. Reassess. 500 bullets. Let's go back and reassess. Start thinking transfer right away. You know what I mean? Like anticipating. Exactly. Okay, good. And I mean, this whole idea of the 1-to-1-to-1, if you have that opportunity, I know where Kat works at Joe's, it's really cool. They've got whole blood. And that's a decision that the trauma team makes at the beginning. Patient arrives, are we going component or are we going whole blood? And that's a decision the team all makes together very quickly, obviously. But then they would choose that route. And then the patient gets this nice big fat bag of blood. It's pretty interesting, actually. So, just to sort of simplify, I'm not going to go back to my slides now. It's okay. But just the idea that, with this patient, you may challenge him with some fluids, you may give him 500 ml boluses, you might go directly to blood, but you're never going to pummel him so badly. You're not going to aim for that blood pressure of 120/80 because it's not necessary and it's not maybe good for him. You're going to keep him warm, and you're going to resuscitate as carefully as you can, maybe considering that a MAP of 55 is what your team is happy with. And, resuscitating again with blood first as opposed to anything else. And then considering, well, Tara, if you're going to give 6 units of blood, I'm sure your trauma surgeons are asking you for some calcium gluconate or calcium fluoride, whichever one your center prefers to use. In any case, I think it's just the idea is, just to sort of really to conclude, is that the damage control resuscitation of the trauma bay has to be done early. It has to be done mindfully. It has to be done, you have to anticipate thinking about what your patient really needs, with the idea that prevention is so much better than trying to chase your tail and get out of this triad of death. You need to put a stop to that vicious cycle and prevent your patient from circling the drain. If you can do that carefully, using those 6 concepts, your patient's going to have better outcomes. And so as trauma nurses, I think that, not to put pressure on you guys, but I think that we really have the opportunity to really make a pretty big difference in a patient's life by, again, being leaders in the trauma bay, being nurse leaders, and really pushing for change and appropriate resuscitation. We all have a voice, and we all should be really ensuring that we use that voice when we're caring for our patients, because you are the patient's best advocate always. And, if you've been around that trauma bay long enough, you know what it should be done. So
Right.
it's good to have
I found this interesting, Cathlyn, because I'm thinking what I can do with my resources.
Yes.
The satellite. And I just even like the idea of the bear hugger. I was thinking when you were saying that, you put it underneath them. We do
Isn't
have a
that
bear
cool?
hugger. We have a lot of cool equipment. We just don't have the humans to use some of this. But that would be, it's kind of like a warm nest, because it would kind of, blow up around them, and then you put the blanket over them, and that would, really kind of contain the warmth better than, because I never really thought the bear huggers were great on top of you anyway. So
they blow off and you're trying to keep them down in the blanket, or but I think that's an interesting idea for sure. Yeah,
right.
for sure.
Yeah, I'm just trying to take the takeaways that, think what I can do at my school.
I mean, you must have fluid warmers as well, Jenny.
We do.
Ways
We do
to get things warm, and again, it's just also being on the same page as your team. Let's assess, reassess. Let's just be smart about how we do everything.
Mm-hmm.
So
it's a good reminder that the 500 boluses, instead of hanging 2 liters,
2 liters.
Once running in,
in trauma, the rule of 25% is really there, because not only is 25% of our patients in some form of coagulopathy, but about 25% of them, and actually sometimes closer to 30%, are hypothermic when they come in the door from the field. So I think anything we can do to conserve their heat and keep them on that normalcy is ultimately going to be what saves them. And I think if I had my way, we don't have any more wall space in our trauma base, but I'd put up the big old triad of death, because I think everyone needs to be staring at that, thinking about it. And I think if that was in front of people's faces, I think we'd be a little more cognizant in how we resuscitate patients.
Definitely.
Questions, comments? What do you guys think?
Yeah, it was very good, very interesting.
Okay.
I still kind of miss those days of trauma, but not really at this point in my career. But
and another thing too is to keep in mind that this actually does go for many different types of patients. Like just the whole concept of perfusion, just considering what does it take for your patient to really perfuse, whether it's an MI or whether it's somebody who is just arrested. Like we may not warm up every arrest patient, although temperature targeted management is not necessarily what we thought it was either. So just always being, and it's this idea of anticipation for sure.
And one thing I'll throw out there particularly is the threshold for hypotension in the geriatric patient population.
Yes.
That's actually a little bit higher. You're looking at about 110 systolic, and you don't really want them too much below that. And I think we're seeing that now in a lot of our trauma triage guidelines that are coming out, and have evolved that to where we see that 110 being important for the elderly, about 100 for those head injured patients, if you will. And then, somewhere you see the literature between 70 and 90 when it comes to the more traditional patients that are hemorrhaged without had a head injury and without being elderly. So kind of those litmus tests are out there. And I don't know if anybody have heard about it. I'm on my bandwagon for this now, but if you've not heard the term shock index, put that into your vernacular. The shock index has evolved to being one of the better predictive models for determining severe injury and trauma patients. If you haven't heard of the shock index, when you get the link to tonight's video, go to my YouTube channel and look at the shock index journal article we did just about a month ago. To put it really simply, shock index is basically the heart rate divided by the systolic blood pressure. And as a general rule, shock index in an adult of 1 is indicative of shock. And they've done enough studies now on the shock index to show that it is a much better predictor of severe injury and the need for blood transfusion than just systolic blood pressure alone. Any questions for Cathlyn?
I have no questions, but I will say from a data standpoint, Ms. Cathlyn, this information has been very, very interesting and also very useful. And we have, again, from a data standpoint, we get report cards from the ACS and also benchmark reports, those kind of things. A lot of this information that you've said tonight can be applicable when we do our drill down process and things like that. So this has been great. I appreciate the time to be here.
Well, I'm glad you're able to jump on because it's cool.
Yeah, for the information that that Shiloh was talking about is it's in every quarter, I believe it is, that the American College of Surgery puts out what's called a TQIP report. And that basically is a benchmark data. It really shows how you're doing against the rest of the trauma world. And having a good understanding, particularly in damage control resuscitation, because it's a big thing to be looking at now, really helps you understand those reports when they come around. So you're not going to see those reports unless you're working in a level 1 or level 2 trauma center, unless you're part of the trauma program. Or Tara, if you actually reach out and ask someone like Lisa or Tim or somebody and say, I want to see your TQIP report, you'll impress the hell out of them. But you'll really see, fundamentally, there's some really cool data that's out there that we're looking at on a quarterly basis.
Tim, actually, I worked with him last year because I was co-chair of the trauma committee that we had, and they did it for mass transfusion and where we were falling short. So it was actually interesting to see because I didn't know that they were, what we do nursing wise in the department isn't necessarily what Tim and Lisa are working on. So we're not always privileged to certain information. So it was really good to see from a nursing standpoint, because we were able to give education to our nurses in the department and say, hey, this is where our deficits are. So it was really great information to have.
Yeah, I think I see. And hey, Cathlyn, here's something to think about. It just popped into my mind. I think it should be compulsory that all trauma nurses have to spend maybe a requisite month shadowing trauma admin, going through and looking at what the injury prevention coordinator does, the QI person does, the registrar does, just for no other reason than to truly understand what is a trauma center and what makes up a trauma system and a program. Because I'll tell you, I was a trauma nurse for 30 years. And until I went and crossed over into the program side, I didn't have a freaking clue as to what really goes on. And it is impressive. And I know Shiloh's wagging her head because she's been there for many, many years. And it's unbelievable what goes on. It's intimidating. You can be the best clinician in the world, but when you jump onto that administrative side, wow, man, testicles went all the way up into the abdomen. It's like...
No, it's true. I think there's a whole world to the trauma programs that we know nothing about. I absolutely 100% agree with you. Yeah. And there's so much what the American College wants from each trauma center and what the state wants in terms of information. It's overwhelming. I mean, and it's demanded. So it's very interesting. Well, that can be so. I think that's something we need to consider. Maybe Tara, we can do a little pilot at your place and see what we can do about that.
Sure. So I'm actually going. I would love to volunteer for anything because I'm doing my master's in education, and yes, so I am like a huge proponent for as much education for our nurses because I feel like we're like when they come out of the bay, and you give a trauma patient to a fairly new nurse. And so we talk about the reassess. Sometimes it can be concerning, you have a patient sitting in a hallway who was a trauma patient and we try to like educate them as senior nurses, but whatever happened to that course? Remember TCAR?
Yep.
What happened to that? Did we?
It's
did we
still
still there.
exists.
It's still
Still
out
there.
there. Yep, it's
Yeah.
still there.
Because I think, that would be something I know I would like to take, because I've never taken that.
It's traditionally more of an ICU course, but I
Right.
agree. It's, considering how long we end up holding trauma patients in the ED,
Right.
it doesn't hurt to understand the hemodynamic. Like, it's something in the NAEAS probably has a much better grip on, because she works in critical care.
Yeah.
That, you're used to the daily or the minute-to-minute hemodynamic monitoring and adjustment. And that is a skill. That's an art. That is not, and it's something as emergency nurses, we're jacks of all trades, kind of mashes, and none. We can hold our own there, but not the way the ICU nurses can.
Yeah,
Yeah,
and
that's why
even-
when I went to the ICU, I was like, oh, wow, there's so much more that we are not privy to in the ER. But
Oh, we
we're-
just don't have time for. We don't have
Yeah.
time for it.
Correct, very much so. And even TNCC, as much as I have been an advocate since TNCC was the first class was given all those many years ago, TNCC is really geared not toward those of us that work daily in the trauma bay. It is geared toward those people in community hospitals that don't see trauma that often or see it episodically, so that you can do the initial care and then do the handoff and get them to, referred as needed. And I think there's always been a bit of a vacuum that I think ENA needs to address. And maybe they can collaborate with the Society for Trauma Nurses on putting together a trauma course for trauma nurses.
An advanced
And
trauma,
very
advanced trauma
much so.
program.
The physicians have started to do this on the surgeon side. They're getting away from ATLS and they're looking at some of these courses like ADAM and ASSET and BEST. I think on the nursing side, we need to also be thinking about beyond TNCC. So that would be
Steve, that could be the
Yeah.
next thing you build. Is
There
that what
you
you're gonna
go.
make?
Well, if I do it, you do it.
Oh, that means Tara does it. Yeah. No, I think you're right, because I think TNCC is a good base, and if you've never taken it before, it's one of the most important
Yes.
base courses for an emergency nurse. But it's not going to teach you how to function in your own trauma bay. Quite honestly, it won't teach you how to use the rapid infuser, or to it's a beginning, or how to be a leader in the trauma bay.
Right.
So yeah, I agree with you. Maybe we need to resolution. Steve, you want to put a resolution into the ENA National?
Yeah, you got me doing more work. We'll chat this weekend.
And good times. I hope you're all ENA members. We'll put a little plug for ENA as well. Really important that we're part of our professional organization. It just gives us so much back as well. And thanks for having me tonight, guys. It's been really fun.
Thanks so much, Cathlyn. I can't thank you enough for being here. Applause around the board.
Thank you.
Well, it's good. It's good to talk trauma. It's good.
Thank you.
It's good to be together.
So in the chat box is the link to evaluation. If you want CE credit, please click on that. It'll take you right to a survey, monkey survey. Take you no time to fill it out. Give us your feedback. Would love to hear what you think about tonight. And then also, if you're interested, you're not already signed up to be on Steve's email list for future topics and or nursing journal club. We'll put you on that list and send you out not merciless communication, but we'll at least communicate with you respectfully when new episodes come up. And you'll get the link to this program that you can share with some of your colleagues if you thought tonight's content was certainly share worthy. So
what I would challenge all of you is for Steve's journal club, the next journal club, or for the next presentation you have, I challenge you to bring one more person with you from your team or from your department, and make sure that they, join you. And then then the next time everybody has to bring one more person. And guess what? Next thing you know, you have, 30 people getting together to talk about these topics. It's really important for us to be together to do these things. So thank you,
Absolutely.
Steve, for taking the initiative to make it happen. It's really cool.
Thank you.
no, thank you all for being here. Again, thanks again for being here. Go back, enjoy the rest of your evening, and we'll see you on the next topics.
Great.
Thank you.
Thank
Thank
you.
you. Bye, everybody.
Elizabeth, we'll get you into TNCC, Elizabeth.